Good morning, ladies and gentlemen. It's my pleasure and honor to contribute to this session, how to overcome the most clinically relevant challenges in TAVI. This is a very practical session. It's sponsored by Medtronic. It will last 60 minutes. And with me, I have the pleasure and the honor of working together with colleagues and friends, Dr. Vasilis Panoulas from Royal Brompton in London, Christopher Russell, Dr. Russell from Norway, the University Hospital of Oslo, Dr. Hannah Vaknin from the Rabin Medical Center in Israel, and Dr. Lisbeth Russelt from Aalst, Belgium, actually the place where I trained when I was her age. So I'm very happy to have her on the team and all these very expert people. This is a session dedicated to some very important points on our clinical practice of changing aortic valves. And we want to share with you some learning points about the implications of patient-prosthesis mismatch. This is a very important point, sometimes not well known, not well understood, but this will not be the case after this session, because you will know and you will understand how important this is for our daily practice. We want to share with you about learning the importance of valve aortic commissure to coronary alignment and how to control valve implantation to optimize this aspect of TAVI, which is also very, very important, particularly with our supraannular self-expandable valve, but with all valves in general. And then to discuss options to overcome common daily challenges of TAVI. Patients may have more than expected complexities, and there are valves that are easier, more difficult to implant. And so we will discuss a case with association of peripheral vascular disease, tortuosity, horizontal aorta, asymmetric valve calcifications in large or in very small annuli. So there is a wide spectrum of really daily problems in our practice that will be addressed during the next 60 minutes. So to start, I will invite Dr. Vasilis Panoulas to tell us which is the relevance of this issue of prosthesis patients mismatch.
Thank you very much, Flavio, and welcome everyone to this session. Just a quick reminder also, so we can make this as active and as participating as possible. If you go to your main app of PCR, the main page, if you go down left, it says course, and then there's a middle big button called interact. So if you click on that and then go to the room 241, you will be able to send questions, participate in polls, etc. And maybe give it a go now during my boring talk, because then we want you to be more awake, okay? So I'm here to talk about the clinical relevance of prosthesis patient mismatch. And to start with, what is prosthesis patient mismatch? As we all know, the native aortic valve has an area probably 3 centimeters squared and more, as you can see here in the graph, but most bioprosthetic valves fall into the area between 1 and 2. So already we're talking about the smaller orifice area compared to what's actually normal for us. And then here comes the patient prosthesis mismatch parameters. When our indexed effective orifice area at rest is below 0.85, you start having mismatch, and that's moderate. And if it falls below the 0.65, it's called severe. Obviously, there's different cutoffs for people with BMI above 30. They're a bit lower, but this is kind of the graphic estimation of where the majority of the valves fall and what we call indexed orifice area and what we call mismatch. Here you can see the mean gradients at rest and during exertion in patients with and without PPM after surgical aortic valve replacement. And as you can see, from rest to maximal workload, there's quite a big difference in the mean peak gradients with those that have and don't have the mismatch. And obviously, there's also studies that have shown as your cardiac output increases, your mean gradient also goes up. Now, what is the clinical relevance? So why are we interested in that? Because, you know, people might say, okay, so what? My patient has severe patient prosthesis mismatch after the TAVI I did to him. So what happened? Here you go, some data first of all in surgical aortic valve replacements. So this is a study on 60,000 patients over 65 years that had isolated AVR between 2004 and 14. And you can see the presence of moderate mismatch was 54%. So over half of the surgical AVRs have mismatch. And 1 in 10, 11%, have severe patient prosthesis mismatch. And what does that mean for my patient? So that patient that comes out of theater and has severe mismatch, as you can see, is going to have a higher mortality rate 10 years down the line, is going to have higher chances of hospital admissions with heart failure, and is going to have much higher chances of having a redo valve down the line. So actually, having severe patient prosthesis mismatch is bad for you. Increases your mortality, increases your hospitalization, and increases the reintervention risk down the line. And these are important data. And someone might say, oh, well, but I think we have solved the problem with TAVI. I don't think it's that relevant with TAVI. But here is a study from Herman from 2018 on TVT data on 62,000 TAVI patients, which included both balloon expandable and self-expandable valves. And you can see here that severe prosthesis patient mismatch remains at a 12.1%. So there's still 1 in 10 of your TAVI patients will end up having severe prosthesis patient mismatch. And you can see also grammatically in the histogram where these cutoffs are that we spoke to before. Now again, someone might say, so what? What does that mean for my patient clinically? Does that mean they're more likely to die down the line? And the answer is yes, they are more likely to die down the line if they come out with severe PPM. And you can see that graphically there. And that also seems to be significant already from the first year. So it's quite an important finding for your patient. And then someone might say, what are the predictors of PPM in people that undergo TAVI? And here you can see, obviously, being generally smaller females, doing a valve-in-valve procedure, and using valve sizes less or equal to 23 millimeters are independent predictors of having more mismatch. And what about females? We did that study quite some time ago. And you can see that from the WIN registry, that was all females, you can see that within the TAVI there is a PPM in 36% nearly. And obviously if you use valves smaller than 23, that goes up to 50%. If you use balloon expandable, 43%. And if you use self-expanding, it goes down to only 19.6%. So quite a big difference between balloon and self-expandable rates of mismatch in TAVI when we're talking about females. Does that also has a clinical impact? The answer again is yes. And again, you can see that severe PPM at women, it makes them at higher risk of death, stroke, or rehospitalization. And what about the pre-existing severe patient prosthesis mismatch in valve-in-valve procedures? So it seems that if you see that study down left in 1,000 patients with previous aortic valve replacements, already 7.6 had severe patient prosthesis mismatch. And when you go and put the TAVI in those valve, then it associates with obviously elevated gradients and high mortalities at 30 days and a year. And obviously you can see that if you use a self-expanding valve, you reduce that risk of having higher gradients in the severe PPM group. So if you do plan on doing a valve-in-valve in someone who has already severe PPM from a previous AVR, probably the safest choice would be a self-expanding valve. And again, what about this link between PPM and structural valve generation? As you can see, PPM is associated with the stenosis type of SVD, and that normally starts to occur after 2 to 3 years. The regurgitation side of things comes a lot later, but the stenotic type SVD is going to come after 2 years. And you can see there again the independent predictors. And I'll just finish off. I think you heard about the SMART trial earlier on this morning for those that were in the presentation of Roxana, but just as a reminder to everyone, this was a big randomized trial for patients with small annuli, less or equal to 430 millimeters square, by CT and severe symptomatic aortic stenosis. They were randomized to a Medtronic Evolut self-expanding valve or the balloon expandable Edwards Sapien 3 and 3 Ultra. And you can see the co-primary endpoint 1 and 2. In the co-primary endpoint 2, as you can see inside, there is a non-structural valve dysfunction, which includes severe patient-prosthesis mismatch, according to the VARC-3 criteria, and more or equal moderate total AR. And as you can see in the little graphs in the middle and down right, you can see that within the self-expanding valve group, the severe prosthesis patient mismatch was only 3% compared to 9.8% in the balloon expandable valve. So it's a significant difference between the two. There was, in fact, slightly lower aortic regurgitation in the self-expanding valve group. And more importantly, you can see that from this study, there was a significant difference in KCCQ ordinal outcomes at 12 months, which means that people that had self-expanding valve felt better down the line. And probably one of the reasons might be that they had a fewer number of cases that had severe PPM. So this is just take-home message for you to remember. Of course, the co-primary endpoint number 1 didn't show any significant difference in the all-cause mortality, stroke, and rehospitalization, but probably this is a bit early days for that to show up. And I just want to finish off that, of course, size matters, and nobody wants a small estimated orifice area. And thank you very much for your attention.
Thank you, Vas. I mean, regarding the small cup of coffee, I mean, Italians, we like small cups of coffee. We don't like this big, large American cup of coffee. But anyway, wow. Now we go in practical. Vas has just explained how important it is avoiding PPM. PPM is changing a native aortic stenosis for a prosthetic aortic stenosis. And so it's at least a moderate aortic stenosis, can be even severe. So when is the relationship in between the size of the aortic annulus and the size of the patient? So if you have small lady, very overweight, PPM is for sure. So this should be a contraindication for surgery, and it's a challenge for TAVI. So just to make this clear, I will show you the example of a very small lady with a very, very small annulus. And this is a lady I did last year. She comes from Sardinia, which is a Mediterranean island where there are small people, big people, but also small people. She had surgery in 2012, more than 10 years ago, because of a subaortic membrane aortic stenosis. She did well for nearly 10 years, and she became symptomatic. At the same time, she was on chronic steroid therapy, which is, again, a relative contraindication for surgery. Very symptomatic, syncope, dyspnea, normal ejection fraction, normal kidneys, normal coronary arteries. Very small annulus. So look at that. Sinus of Valsalva, 22 millimeters. ST junction, less than 20, 19.7. And annulus, 15 millimeters. 15, 16, 12. An area of 1.7, a perimeter of less than 5. So is the smallest TAVI I have ever done. Nice coronary arteries, no risk of occlusion because are quite high. Very little calcium. It's a fibrotic recurrence of aortic stenosis. Very nice peripheral circulation. So you see that these patients does not fit any of the available valves. If these patients were included in the SMART trial, would have been excluded because it's too small for either the balloon expandable or the self-expandable. There is no doubt about the severity of the aortic stenosis. Is peak gradient 87 millimeters of mercury, mean gradient more than 50. So the question for you is, would you treat this patient with TAVI, yes or no? For sure, the surgeons didn't want to treat her again. The first time they didn't implant a valve, they did a subvalvular myotomy. But this time, of course, they don't want to reoperate, also because of the long-lasting therapy with corticosteroids. Okay, so you are very expert TAVI implanters. More than 80% would treat the patient with. The question is, which kind of valve? Vas has just explained the difference in having residual gradients and PPM in between self-expandable and balloon expandable. So this is what we did. The patient was implanted an Evolut 23. Remember that the area of the SMART trial was 430, and this lady has less than 200. So it's less than the half of the annuli that were included in the trial. This is the final result. The peak gradient is 14, and the mean gradient is 8. So it was better than expected. And another issue is now, let's see whether we avoid the ppm. So the projected index area to avoid ppm is more than 85 centimeters of valve per square meter of the surface body of the patient. With an Evolut 23 in a patient with 1.5 square meters of BSA and a derived perimeter of 24 millimeters and a reference area of 1.66 in the 23 Evolut area, we have more than 1.1. So we have a bigger valve that she was made by her mother. So she got a bigger valve than what she had in a native aortic annulus. So there is absolutely no ppm in this very small annulus. It's true that the patient was also small. That makes things, the relationship easier, more favorable. She had an uneventful hospital course. And again, to our surprise, despite the very, very small annulus, she didn't develop any kind of AB conduction, and we have 1 year follow-up of the patient doing very well. So after that, we have time for discussions.
Absolutely. And we have also some questions for the audience. There was one case that was asking if there's a difference between crackable and non-crackable surgical valves in addressing the mismatch after valve-in-valve. I think that's an important question, and I guess Fabio, I mean, you want to make a start?
If we stay on the SMART trial did not implant valves in valves. It's all about native valve. If we go to valve-in-valve, I mean, cracking some of the surgical valves, it's a very good option to make the orifice bigger and you reduce the gradient. And this should be considered anytime you have a residual gradient more than 20 millimeters of mercury when you have implanted your valve. And needless to say that the residual gradient in valve-in-valve procedures is lower when you implant supraannular self-expandable rather than any intraannular valve.
No, I agree with those sentiments. I think that it's important to adjust during the procedure to actually see what you get. And so the plan has to be taken out of the hemodynamics that you get after you've done the initial implantation. Sometimes you can get away with really nice hemodynamics, even though you thought it might be a little bit narrow starting off. So I think that's a good point, to use the hemodynamics during the procedure.
Mm-hmm. Is there any question from you? I mean, is it clear? We will dedicate 5 minutes to this discussion. We want you to go home that ppm is important and how to solve it. We have Ron.
Did you use a CAS overlap view during the implantation?
Always. Just for simplicity and making it short, I showed the release projection, but of course.
Based on the company published data about orifice of the valve and the height of the patients and the annular size, you can predict. And if you predict, you can make the calculation before, and you, based on the calculation you measure, you think this patient is high likely to have significant prosthesis mismatch. Do you still go ahead with the procedure and hoping for hemodynamic will not be?
That's a very, very, very good question. If you put a balloon expandable, you know that the valve will be that size. First, you have risk of annulus rupture because you have the balloon. This is a self-expandable. So if you're not happy with the result because you have leak, you have total AV block, or the valve is jumping, it's a retractable valve. You can take it out and leave it as it is. And then what you expect with this calculated area is that you will not have, if you put a 23 in this patient, you will never have PPI. And this is why I decided to put this kind of valve.
If I can comment maybe on your question. So it also, the decision also depends if your surgeon would do a root enlargement or not, if you have to choose between both options. If the patient is suitable for both SAVR and TAVI, I think if the surgeon can do a root enlargement, maybe in that case for that patient it's the best option.
Yes, please.
Thank you. How would you address low coronary takeoffs in a similar patient in terms of the choice of the valve, the implantation technique, or whether you would do it or not do it? And what is the minimum height you would accept?
Anyone wants to, I mean, it's not also to me, does anyone want to address that? Lisbeth?
Well, if you have low coronary arteries in a small anatomy, and often they come together, you will need to look at it, of course. And if you have this issue, again, you have to ask yourself, can I do SAVR in this patient? Because this is really a devastating complication if you would have coronary artery obstruction, and the mortality of this is very high. And in case this patient is not suitable for surgery, then you need to look at other options, try to predict what is the risk for coronary obstruction. And maybe you need to modify the leaflet, or you can choose your valve, implant it a little bit deeper, or you can go for a protection, coronary protection with or without a final chimney stenting.
Basically, it's a decision you take before accepting the patient. If the risk is prohibitive and you don't feel comfortable with protection measures, of course you don't do it because the risk of death is very high. But if you have good techniques for protecting the coronaries, you can proceed.
There's also a question on the chat here. So there's one question about, does the depth of implantation predict patient prosthesis mismatch, especially in the self-expanding valve? I mean, to my knowledge, I haven't really seen a difference in implanting deeper or not, but I would be curious to see what other people think.
And under very practical standpoints, considering that you are very expert, because 80% of you would have done this case, I really thought twice before accepting. My plan was a lower implantation, because you know that the shape of the valve is flared, so I thought, the annulus is very small, I go deeper, so there will be less compression of the valve. Because having it in a high implantation, the risk of popping up is very high. Actually, being a non-calcific valve, the valve stays very, very well at a very good depth. And as you have seen, there was not even an interaction with the conduction system. So the good of this valve is that you can leave it there, it works, you wait, it's stable, you can evaluate the gradient, you can evaluate the paravalvular leak and the conduction system. So in this case was easier than expected, I should say.
And there's another question about, Fabio, that you showed predicted ppm. How do you compare with a measured ppm with gradients?
Who wants to answer that? I mean, major ppm is not the gradient, it's the relationship in between the area and of the valve and the area of the body surface of the valve, of the patient. So you can know it, I mean, with a piece of paper. There is a calculator, I have to say. It's a free access supported by Medtronic. You can calculate ppm on the website. So this has nothing to do with the gradient. The gradient is something you will measure after you implanted the valve.
I do have a point that this sort of highlights yet another thing that we have to think about when we are planning the procedure. So it's not just the anatomy and all the challenges there, but it's also what's the valve size we can get in, and putting the anatomy together with the patient size. So it's just one more thing that we have to have on our checklist when we are selecting the valve platform and when we're doing the pre-planning. So I think that's sort of what this study is really highlighted for me, that it's not one valve fits all, but it has to be part of the algorithm for assessing patients.
And very often there's a lot of patients, particularly if you think about evolutes, there's a lot of patients that fall within that 26, 29 range with perimeters in the early 70s. And sometimes you just have to balance, what do you prefer, a bigger valve with the risk a bigger valve can come with, or a smaller valve, but which will create a smaller orifice area. And I think that's, again, something that you calculate in your pre-assessment.
Okay,
yeah.
We move?
We move on.
I know we could spend more time on that, but we have many other things, important things to tell you. And so the next speaker will be Lisbeth. And this is another very, very important and interesting issue, which is commissure to coronaries alignment.
Hello, everybody. So I will be talking about commissural alignment. And maybe it's speculative to say, but maybe commissure alignment can have a good effect on hemodynamics and who knows on leaflet thrombosis or degeneration, but this is still speculative. But what we do know for sure is that if you have a good commissural alignment, you will have easier coronary access and you will keep open the gates for future redo procedures. So if we look to data for engaging selectively the right or the left coronary artery, it's actually quite broad. So in some cases, only 15% was selectively engaged, up to 90%. So this is a very good area of selective engagement. But if we cannot engage, this can be really annoying during a procedure. Now it's depending on two, let's say, characteristics. Of course, if you implant your valve higher, the skirt and the leaflet tissue will end up higher in respect to the coronary, and this might make it more difficult to engage a coronary. But there is also this rotational aspect, and this is what we mean with the commissural alignment. You can see on the right side, if you have your commissural post just in front of the coronary, of course, this will be very difficult to engage this coronary. But we have to put this into perspective. This was a really interesting study, to my opinion, and they looked at patients that needed an unplanned PCI after TAVI over a time course of 10 years, and in total, only 2.3% of patients needed a PCI. Now, this was even lower in patients without any pre-existing coronary artery disease, but much higher, up to 7% in patients with multivessel disease. So maybe we need to be even more careful in these patients for the commissural alignment. And then we introduced in the last years some techniques to modify this rotational aspect during our procedure, because it's one thing to know the theory, but the next thing is, of course, to be able to implant this way. And in these three types of self-expanding TAVI valves, it was quite often possible to have a good alignment or only a mild misalignment. Now, there is some data from the new Evolut FX Evolut valve, these are the retrospective data from in the US, where they already have the device a longer time available. And there was good technical success, there were good short-term outcomes, but when we look specifically to the commissural alignment in these cases, it was quite high. It was up to 96.5% that they've reached commissural alignment. And this probably has to do with the new feature on this FX valve, meaning that there is now 3 dots on the valve that align with the commissures of the leaflets. So this makes it much more easy to understand how we are implanting and what we are doing during the deployment of the valve. Beforehand, we only had this C-tab, and so this matches with one of the 3 commissures. Now, when we go in the procedure, very practical, we will prepare our case with an REO caudal view, which is typically the right-left cusp overlap. We want to do that because we want to have low pacemaker rates, but also we want to align the valve. So the 2 markers, when we look to in the REO caudal view, we will see 2 markers of the valve on the left side and 1 pointing out at the right side, because this is the commissure between the right and the left coronary. If we go to the 3-cusp view, then we will see the 3 dots separated out of each other. And if we go in the end to the areocranial view, which is the right non-cusp overlap, we know that there will be 1 dot on the left side of the screen and the 2 dots at the right side will be overlapping, at least if we have achieved a good commissural alignment. Now, very practically, if we go in our procedure, what we will do is insert the valve with the flush port at 3 o'clock. We once more check this when we were before the arch. We check if the flush port is still at 3 o'clock, and we will see on our screen that the head marker is at the outer curve of the patient, of the aorta. Then we cross in LAO, and we really look at this head marker if it still remains at the outer curve. If this is the case, then we know that we will arrive in a good way at the level of the valve. At this point, when I just crossed the aortic arch, if I'm happy there with the head marker, I proceed. In case it has turned some way, you have to pull the system back and you have to adjust. You have to, for a quarter turn, to reach again this head marker being at the outer side of the aortic arch. And then you proceed and you will go until the level of the valve. And there you will go to the RAO caudal view, which is the right-left cusp overlap view. And you can nicely see in this animation what it does to the nadir points of the valve. And at this point, you will cross the valve. When we start deploying the valve and we start seeing it flaring, we want to see 1 dot at the right side and 2 dots at the left side. That means that we're happy and probably we will reach good commissure alignment, as you can see on the right side in this case example. Here are a few other case examples where we are happy with the view. So we've deployed in all cases up to 90% almost, and we see this dot on the right side of the screen, and we accept this. Then we go forward and we assess the depth of the valve. So the way I do it is I go to the RAO caudal view, and I have to admit it's not perfectly aligned in the left image. But what I do here is I check for depth, and I want to see that at least 2 of the 3 markers that are 3 millimeters away from the bottom of the valve, I want to see at least 2 markers are above the annular plane. Then I turn to my LAO cranial view. I have the 2 dots up onto each other. And here again, I see that at least 2 dots are below the annular plane. So in terms of depth, I am happy to implant this valve and release this valve. I just put this image also in this show. This has not so much to do with the commissure alignment, but I wanted to show, and if you pay attention to the bottom of the valve, it will replay again. If you pay attention to the bottom of the valve and you see the 2 dots, you can see that we have this nice symmetrical implant. So with the previous system, sometimes we saw that there was a left very deep implant and more higher up at the non-cusp. But now we have a more symmetrical implant, and also you see that this jump that we sometimes saw is much has reduced a lot with at the moment we deploy finally the valve. So what I do in the end of the procedure is I go to the right non-cusp overlap view, because I know that there the left coronary is pointing at the right side of the screen. And remember, if we do a coronary angiogram, I go always to the LAO to engage the left coronary. So it makes sense in a way. So just to conclude, to achieve commissural alignment, we need to introduce a system with a flush port at 3 o'clock. We cross the arch in an LAO view with the head marker remaining at the outer curve of the aorta. If we want to adjust the alignment, we have to do it in the descending aorta. And while we deploy in the RAO view, we want to see 2 markers on the left and 1 on the right. We assess the depth, and as a final step to check if we're nicely commissural aligned, you can go to an LAO view, LAO cranial, where you want to see 1 marker at the left and 2 markers at the right side. Now, we had a very interesting discussion during our prep meeting, because we noticed that we have a little bit of a different strategy in the end of the procedure. So I showed you in the end of the procedure, I do this LAO cranial view just to have a look at where is the coronary seated. But of course, this is a little bit diffuse. This doesn't help for example, if the patient would arrive by night having a STEMI of his, let's say, proximal LAD. And Flavio, what he does, he's engaging after every TAVI, almost every TAVI, the left coronary. So our question to you is, would you like to see a coronary catheterization, so an intubation of the left coronary after each TAVI? I'm very curious to see.
I'd say that if you reply no, it's either because you didn't have a good night and you didn't sleep, or you are in the wrong session. Come on, we have prepared that for you. And we will show it to you, okay? Anna will show you a case of good coronary alignment and easy access, and one with, I mean, I will not tell you. I will not tell you. Yes?
So in my experience, I noticed that engaging the right is more challenging.
It is.
So why I should engage the easiest one? I don't go to engage the left.
Oh, well, prognostically, the LAD has two arteries, so prognostically is more often to have to do an MI on the left, is prognostically most important. But we will show you also the right. Yes, you are absolutely right. Yes.
So I will show you example of two cases. One is the first patient is 77 years old woman, who underwent PCI and CABG, and she was admitted. She had TAVI with performed using Evolut Pro 29 device, and during 2022 she was admitted due to a non-STEMI, and underwent a coronary angiography. You can see it, that we had occluded vein graft, and we see that we had stenosis, severe stenosis of the LAD, but the culprit was the CX, as you can see. And this is the right coronary with the moderate lesion at the mid-distal part. 1 year prior to this hospitalization, she had a CT scan to diagnose a suspected HALT. And when we revisited this CT, we saw, according to the coronary misalignment, we saw that there was a misalignment moderately for the left system and severe misalignment of the right coronary artery. There is a nice paper of Yoon et al. In the circulation cardiovascular intervention that show, according to the commissural technique for good alignment, they did post-TAV CT, and they saw that coronary alignment or mild misalignment was achieved in 97% of the cases. For this patient, we managed to cannulate the left coronary non-selectively, put a wire and then extension guiding, and did the angioplasty of the CX and also of the LAD. The second patient is, we did it recently, is a 75 years old female diabetic with minimal effort angina, critical aortic stenosis, 130 over 84, with the hypertrophy, septum of 70 millimeter, not as written, without obstruction, non-obstructive coronary artery, and calcium, you can see in the right panel, severely calcified. And this is the measure. We implanted the Evolut 26. Both the echo and the peak-to-peak showed remarkable hemodynamic, with the peak-to-peak was 110. This is the cusp overlap. We did both cusp overlap view. We predilate the valve with smaller balloon. And I show you that the technique, after we put the 3 o'clock port, but in this case we had to do a small rotation to 1 o'clock in order to get the head marker on the outer curve. And then you can see it in the ascending aorta, in the outer curve, in the cusp overlap, we see the head marker at the center point. After the dilatation, the patient had acute AI with hemodynamic compromise, which resolved after the valve was deployed. But we can see here that it was under-deployed. We remove carefully the nose cone, post-dilate, and you can see here perfectly the depth marker on the inner curve with the C-tab. So angiographically, there is a very good alignment to the coronary. We had a good hemodynamic peak-to-peak, more gradient in the echo due to the hypertrophy. And to prove that there is a commissure alignment, we injected to the coronary. It was easy, to the left and to the right. And this is the question for you. Would you try to get better commissure alignment more than once?
Thank you, Hannah. Since you take time for thinking, the question is whether you put the height on the right side, you cross the arc, it's on the wrong side. You come back, you rotate. How many times would you do that? More than one? That's the question. And Hannah, in the first case, the valve was not well aligned.
Exactly.
That case was done many years ago. So at that time, we were not aware.
We were not aware of the commissural alignment.
We were not aware, so
randomly.
we didn't know the precise technique to attempt at least a good alignment. But in any case, you managed to do the diagnostic cath.
Yes.
The right was, the catheter was far away from the artery, but you had a very good visualization. And in the left, you even managed to do a PCI with an extension catheter. So that shows that even when the alignment is not good, with good technique, you will manage to do an angiogram diagnostic or even an intervention. Can you share with us some tips and tricks how you, when you understand that the valve is not in the good position because the C-tab is not in the good position, the catheter is not going easily, what's your technique?
As I say, in this case, we put the guiding non-selective, and then we managed to put the wire and then extend guide extension. Mm-hmm. And with this technique, we succeed to do the angiography and the PCI also. For this case, we did it only with it was diagnostic, so there wasn't any problem when we saw that there is a good alignment.
Okay. From the panel, which is your? I had a question. Yeah, there. Give you the microphone. Then we go to the panel.
I think it's okay to access the coronary in expert TAVR centers. The problem is centers that are not doing TAVR. What's your opinion about that?
Very important point. This is why there are many sessions at PCR and in other congresses that are dedicated to non-TAVI operators to get learning to get access to the corners. And there is a dedicated session on Friday morning. This is the one I am aware because I am doing that, but there are many others, of course. Other tips and tricks?
Yeah, so I would again emphasize a lot the use of guide extensions, guide liner, telescope, and if you cannot engage the actual osteo, you can engage the sinus. The moment you engage the sinus, you're trying to come as close as you can and then fly a coronary wire in the corner and then use a guide extension. Sometimes you might have to use catheters that don't have primary and secondary bends, like the Judkins Wright 4, for example. That's more straight, so it will not interact too much with struts, and then use your guide liner. And there was also a question on here talking about, it's good to engage after your deployment and it will give you a lot of info, which I think is good also to send it to the referring centers to show this is how you can engage. But there's also the same question says, well, what if you cannot engage? And I guess that's also important info, right? So because it doesn't happen often. To me, I remember one case that the valve was an old valve that was positioned very high. And in fact, the valve was functioning on top of the ST junction, and it was a very small, and it was literally had a tiny slit that was going through the sinuses. And unless you have something like that, I think most of the times you will be able to get into the sinuses. And once you're in the sinuses, somehow one of your wires will manage to get in the coronaries. You might take a bit more time, but these cases that you will not be able to access are very, very rare. But if there is a case like that, again, that's a very useful information to know.
And imagine that all patients that have been treated many years ago when we were not aware about this problem, most of them are dead. So now we're taking more care. And in case it's easy, you just catheterize and you write in the report which catheter with incidence. If it is difficult, as Vas says, you don't need to struggle and give contrast and assume risk, but you say it's very difficult. So hoping that the patient will not need it, but in case of need, the operator will know that he has to take care using, as he said, wires. Non-selective injections are very useful to go with a wire and then follow with either a balloon and anchoring or an extension catheter. You don't need to be selective. This can be painful, long, takes contrast. It's not necessary. The catheter sits on one of the diamonds of the valve and has very good backup, even if it's 1 centimeter out of the ostium. So this is a very practical advice. I don't know, Chris, if you want to comment on that. And
no, I just had a comment on the pole there, because it looked like 70%, it's gone now, but it's 70% would traverse the arch more than once to get commissure alignment. And I just want to point out that, again, it comes back to the patient at hand. We saw the low rates of acute coronary events. And if you have an elderly patient without any coronary artery disease, the likelihood of needing that is low. And so risking traversing the arch too many times, that's not innate either. So you have to manage the risk between going up and down over the arch versus having the ability to enter the coronaries at a later stage, maybe. So it's one of the things to take into account.
It's absolutely important who is the patient. If there is a tortuous or very calcified anatomy, so I don't think that we should insist on commissural alignment if there is a problem. But if it's a young patient and we think for lifetime management, TAVI in TAVs, I think it's important.
One technique that I found for coronary angiography is using the diagnostic catheter and then wire the lesion or the vessel with the coronary wire and made the exchange over this wire. So it can be easy.
If you want my advice, never use a diagnostic catheter. Use a guiding catheter. It's the same French. It's much larger lumen. You can use the 0.35 wire to make contrast. And then if you need to access with a balloon, you are there. I mean, you make the job only. Never use a diagnostic unless you are just trying to catheterize after the implantation. But in need, use a guiding catheter.
Okay, so the take-home message is coronary commissural alignment should become an integral step of the TAVI procedure. The newest generation Evolute FX system with the 3 depth markers aligned with the valve commissure follow center head marker in the cusp overlap view has the potential to substantially improve commissural alignment and subsequent coronary access. Commissural alignment should impact the coronary access, THV hemodynamics, and the feasibility of redo TAVR.
Thank you.
Thank you.
Thank you, Hannah.
Okay, and if then we introduce the last speaker, and we have Christopher Russell, who's going to talk to us about the analysis of frequent challenges in TAVI, large, fused, calcified, and horizontal. Christopher.
Yeah, so we're moving away from the small anatomies of Sicily and to slightly larger anatomy of the Nordics. These are my disclosures. So the patient I want to present is a 73-year-old gentleman. He presented with New York Heart Association Class 2. Previous medical history includes atrial fibrillation. He's been treated for lower leg claudication twice, and he also has hypertension. So the angiography showed non-significant atherosclerosis, and on echo we saw a well-functioning left ventricle and a heavily calcified stenotic aortic valve with mean gradients of 68 and an estimated area of 0.6 square centimeters. So when we look at the valve itself on CT, we can see that the annulus is quite large. It's a little bit over 91 in perimeter with an area of 653. And we can also see that there is a calcification and a fusion between the right and the left coronary cusp, and it's quite heavily calcified. Now, if you look at the intercommissural distance, This is 29, both at 4 millimeters and at 8 millimeters. And why is this important? Well, it's important to define and see what the anatomy is like. If it's tubular, if it's flared, this has a implication on sizing of the valve. So, which is often the case with bicuspid valves, the aorta is also quite horizontal. This is based on the CT, of course, with degrees of 60. We can see that the S-curve is quite narrow. So this is also a challenge that we see quite often. On top of that, in this patient, we have the STJ junction, which here is quite calcified, and it also measures 27 by 27. So if you remember, the annulus was an average of 29, so relative to the annulus is actually smaller. So this also has implications on the valve platform that we use and for further treatment. Now, we thought, based on the previous history of claudication, that access would be a problem, but fortunately for us, there was a good dimension, a little bit of calcium, but okay access. So as we all know, bicuspid aortic valve is like a spectrum or a continuum all the way from partially fused raphe to the two sinus anatomy with true bicuspid valves. And I think our patient falls between partially fused and fused raphe with the fusion between the right and left coronary cusps, and this is heavily calcified. So, would you use a self-expandable FX Evolute to treat this patient?
We can go briefly from the panel. I mean, is that a good case for horizontal aorta large annulus, Lisbeth?
There's many challenges. Horizontality and bicuspidity, that's challenging. But I would say I prefer, it's bicuspidity, so I prefer more a self-expanding device than a more aggressive, maybe balloon expandable device because of the raphe. And of course, now with the FX, we have this more, it bends more, so it will align more with native anatomy. So that, yeah, I would say yes.
We have many Evolute believers.
Yeah, that's evident. Well, that's good. Okay, so of course the patient was discussed at a heart team meeting. His personal preference was to go with TAVI, and I think that was not a bad choice. For me, when you have this anatomy, there's a bit of an X factor on how this calcified raphe will react in pre-dilatation, but also in subsequent valve implantation. And so we saw the intercommissural distance was 29, so there's a bit of discrepancy between placing a 29 valve if you can't dilate properly versus a 34. So I get a lot of information by choosing an adequately sized balloon and doing a pre-dilatation, in this case in a cusp overlap, which shows you then what happens to this calcified area. And if you can appreciate here, so this is a 26 balloon, so it's quite aggressive, but we're planning on a big valve anyway, and you can see the way that it pushes the calcium away, and you have no indentation on the balloon. So when I see this, gives me the confidence to size based on the annulus, and for this patient, that means a Evolute 34. So let's just get that up here. So here's the initial implantation, and as Lisbeth was saying, and you can appreciate here as well, with the FX system, you're able to manipulate the delivery system so that it takes the outer curvature, at least centralizes in the aorta. And what this means is that you get a more coaxial alignment during deployment, and for me, that means a more reliable both deployment and release. So what you see is what you get. So we were happy. We released and we have nice hemodynamics, peak to peak of 1 millimeter, mean gradient of 2. And when you zoom out, you can really appreciate the horizontal nature of this anatomy. And in fact, when you measure afterwards on the angle of the valve, it's almost 70 degrees. And I think I see this quite often. I think maybe one of the reasons is that during the CT scan, the patient is told to have a breath hold. And if this is done in deep inspiration, some of the angulation of the aorta will be taken out. And so if it's horizontal on CT, it's going to be horizontal in real life as well. Again, back to what Lisbeth was saying about the commissural alignment. We can see the C-tab here and the gold radial peak marker. So both these are situated at the commissure. And in a cusp overlap, we want this to take the outer curvature. So this means that we're confident that we have a good commissural alignment. So the next day, we have what we always want to see. We have a nice gradient and no PVL identified on echo. So it doesn't really stop there, and this is part of the pre-planning because although we have good data now showing us the reliable durability of this valve platform, we always need to plan for potential TAVI and TAVIs, 73-year-old patient that we have here. So in this case, we also have the issue of the STJ, which was narrower than the annulus. So what we want to avoid is to get in a situation where a potential neoskirt, so the leaflets of the evolute, go all the way up to the STJ and thereby leave us in a situation where we can get sequestration or strangulation of the ST or the sinus, which is devastating, or will need to the need for leaflet modification. So we looked at this beforehand, and when we had an implant of 2 to 3 millimeters below the zero annular level, we could implant or estimate an implant of a TAVI and TAV at node 5, which gives us minimal leaflet overhang. And as you see there, this gives us a neoskirt or an estimated neoskirt of 23 millimeters, and this keeps us away from the STJ and also gives us an idea of the area surrounding the coronary ostia, which is also sufficient. So I think take-home messages here is that for me, TAVI has become more and more pre-planning. I think rigorous pre-planning is essential to achieve safe and optimal outcome. I think combining information with the different sizing algorithms that we have may aid in valve size decision making. And as you saw now, the improved FX delivery system allows for a more coaxial and hence predictable deployment even in challenging anatomy. And finally, I think a thorough understanding of the valve and delivery system capabilities will increase confidence when choosing valve platform best suited for the anatomy at hand. Thank you.
Okay. These people from the north are so good in planning that you're also planning the next valve for this patient, which will be happening 15 years. I mean, congratulations. This is more than what we expected. We are a little bit late, so we have to close. It's a pity we have to leave because, of course, we could have much more questions and things to say. Before I read what is written there, is there important question that you want to address? Yes, please. This is more important than reading what is written.
So is there still a cut-off angle not to implant TAVI? Is 70 degrees still the cutoff, or has that changed?
Is there a cutoff of horizontality that you do not implant TAVI?
Depends on your experience. There is no cutoff. There is no dedicated. I mean, if you feel comfortable, you do it because cannot be more than horizontal. You know, it's zero. It's horizontal.
So the only I think place that there is a problem is when you go right transaxillary. Then it becomes a little bit of a problem if you exceed, normally the company says 30 degrees, but in my experience up to 60 you can get away. More than 60, more horizontal from the right can be very challenging if you go axillary. Femoral, no.
But from femoral, there is no limit. No, it depends on your experience. Any other burning question? Yes.
Yes, my question is pertaining to patient-prosthesis mismatch. In a small annulus, and very severely calcified valve, which we experience in Asian countries. After deploying the valve, because of the calcium, especially annular calcium, at what threshold will you say enough, I'm not going to dilate post-deployment?
I think that it depends on the residual gradient at this point.
Yes, that's at what residual gradient? Which is more important, residual gradient or possibility of annular rupture or damage?
This is part of the art of our job. Yeah, I try to leave the patient with less than 20 millimeters of mercury, but depends. I mean, if the lady is 86, she can go home with 21 millimeters of mercury alive rather than not. It's different if the patient is 65 and you treat very young patients. So, of course, this is a matter of attention. I agree with you.
But also, it's a good place to put a supraannular valve. So you avoid, even though it's a bit distorted at the bottom of the frame, you can still get a very good leaflet expansion, and the valve is well expanded. So I think that's also important to notice, that the valve is supraannular, right? So even if you have very bulky calcium, you don't need to go crazy with the bottom of the valve frame.
Yeah, for sure, you will get a higher gradient in this situation with the intraannular balloon expansion or with intraannular self-expansion. So the best you can do is put in a supraannular valve, this for sure. Okay, there are no more burning questions. So we did it. Yes, one more before. We have 1 minute. No, but they leave. Okay, make it. Go.
Yeah, sorry. What would you do with a very large annuli perimeter, say more than 110, not a surgical candidate? Would you
we regularly, when you have experience, we regularly treat patients off-label with more than 110. It depends on your own experience, the experience of the team. You can do that. Depends on several variables, the quantity of calcium, the LV function, but you can try.
Would you put a balloon expandable and oversize?
Also, depends on your experience. I'm saying experience, not the type of valve. Okay, I thank you very much and wish you a nice end of the day in Paris.